Good morning. It's good to be back here. I want to thank Dr. Sarthak sir for inviting me. So I'll be talking on posterior labral tears, how to tackle. So is posterior just the mirror of anterior? It is definitely not. These behave completely differently, as we see more of flaps, cracks, buckets, and these posterior labrums are much weaker. So that's the reason more of a scapulothoracic and a scapulomusculature takes a lot of role and a lot of work in these, and we don't see such type of tears in your anterior labrum. And like how anterior tears matters, which tears even in the same posterior also matters, where Kim lesions and the flap buckets have definitely a poorer outcome. And the reason for failure is, like we said, it's a tissue quality is weaker, and it is the weakest at the glenoid insertion part. And introduction would be, we see at least 5 to 20% of posterior labral tears when you're taking a whole of glenohumeral instability, and it was tearing at us from long time, but we are tearing it back. So that is why there is it is improved with the recognition. And in this study where only 8% were seen, and the presentation are usually traumatic because of the posterior force to the anterior shoulder, which is adducted arm, or atraumatic because of the repetitive usage in case of weightlifting, overhead athletes, swimmers, and throwing, or acute on chronic. Who are at risks? People who have a loose joint in case of a swimmers, a weightlifter, who are doing a lot of gymnasts. So these people have a tendency for posterior labral tears. This painful posterior shoulder is a multifactorial. Usually it is seen with the concomitant pathologies, maybe with the slap tears, or a posterior labral with the panlabral tears, or even with the cysts. So what are the different spectrums? It can start from just the labral tears to with the splenoglenoid cyst, or to matter of fact even with the glenoid with the posterior bone loss. And in the labrum it can be even just a normal fraying, bucket tears, and with the Kim lesions. So recognizing the problems. People with posterior labral tear don't come with a frank instability or any giving away sensation. They come with only and only discomfort or posterior shoulder pain. So it is a vague, non-specific posterior pain which increases with usually a posterior directed force, that is the load and shift. And sometimes there may be clicking sensations, and rarely they have a sense of instability. Pain usually in the late phase of the throwing, and majorly with pain rather than the instability. So physical, we have variety of tests for this. It may be a posterior load and shift test, a posterior apprehension test, and a jerk test, or a Kim test. So then choice of investigation would be definitely an MRA. In case of X-ray, if a patient is, if you are suspecting any bone loss, MRA because to see any posterior labral cysts along with the tears, posterior superior impingements, panlabral tears, or slap tears. Indications for me would be failed conservative treatment for 3 to 6 months with a post-physical therapy, persistent pain even with a continued pain or mechanical instability, signs of mechanical instability, concomitant pathology as just described of anterior labral tear with a panlabral tear, or a slap tear associated with slap tear, or a cyst. And definitely all it comes down to the patient-specific factors, depending upon considering their sports level, activity of sports, how back they want to go back to, and the functional goals. So just presenting a case of 30-year-old with a vague posterior pain, clicking sensation, not happy, doesn't have that confidence over the shoulder. A Kim test and jerk test were positive. MRI should just show a posterior labral tear. So this view from the posterior portal, usually first establishing should be anterior-inferior and the anterior-superior portal. Then doing the diagnostic rounds shows a bucket handle kind of tear. Then next would be shifting the portal to the anterior superior portal, classifying the tear or seeing how the tear pattern is, following which then going ahead with the releasing of the posterior labral tear. Here it is not like anterior labral tear, it just releases arm and sits back. And following this, any cysts are present or in an MRI, you have to evacuate this cyst in this step, following which we roughen up the glenoid just at the rim so that it's sufficient enough for the healing. And after this, developing the 7 o'clock portal or the posterior inferior portal or in a percutaneous manner, so that there is a good anchor insertion. And this is usually at the 7 o'clock, this is 6, 7 o'clock, anchor of your choice, either a single loaded or a knotless. So after this would be a straightforward Bankard's kind of repair, but this is easier in case of posterior. Here we wanted just the labral, not the capsulorrhaphy. If it's a capsulorrhaphy, you need to take it from the, if a patient has a lax joint, we need to take it from here, or otherwise a straightforward from the, I would have been happy, a little more towards a capsule in this case. And following which, do a straightforward labral repair. And in this, posterior inferior is the main component, and here we need to just close, we need not have a bumper, so that if a patient has a cyst, this is just to close the one-way valve and nothing more. Similarly, we can go ahead with the more superiorly 2 anchors or 3, depending upon the size of the tear. So, and this has to be at the rim, not as to save the surface of the glenoid, not on or end phase or towards the medial edge. Following which, this is just one more to show this also can be done with a knotless type of knotless anchors. Thank you. Yeah.
How often, hi Sandeep, how often you are getting these posterior labral tears in your routine practice?
Like I said in my first talk, it is there. We are not diagnosing it. So we are getting not that often, but I have a lot of football athletes, not a lot of badminton players. So maybe my setup, I don't have much. Maybe sir can elaborate more on that.
Percentage-wise, these are much lesser than anterior.
Yeah.
But again, the point I would like to make, Sumanth, is that because we see 90% anterior instability, we would expect a lot of cartilage damage, a lot of problems with the anterior instability. I see far more cartilage wear in posterior labrum tears, although they are far less frequent than anterior labral tears. The other thing is we are discussing instability. Like ACL, instability never causes pain. Pain comes when there's complication. And the only way to pick them up is pain. So that means they are, as it is, coming up too late to us. They are very innocent, and you have patients who are playing. I have cricket players, I have tennis players, and they have come in, by the time you see them, they have got grade 4 cartilage wear. A lot of that is probably because of over athletes with a weak posterior cuff, and some of them have a retroverted glenoid. My biggest challenge, and I don't have an answer, and across the world they don't, is you have a 15-degree retroverted glenoid with a cartilage wear and with posterior labrum, what are you going to do? You will repair it, but because of retroversion, the biomechanics is skewed, the head is subluxing out. You look at an axial on the MRI, the head is 50, 60, 70% subluxed posterior, so center of rotation not there. Those are very difficult, they'll never be perfect. I'm actually on Sunday seeing one of our friends from Belgaum, who's an avid tennis player for 30 years, and I've done his repair, he has cartilage wear, and I've stopped his badminton, he's still cursing me. It's 5 years down the line. Good function, but he still wants to play. If he plays, he's going to ruin his shoulder. And at 50, you don't want to do a replacement on them. So, as you quite correctly said, it's not a mirror image of anterior instability. So number one, look for the reverse Ill-Sachs. Usually it's very subtle. Look for the cartilage where you do a poor quality MRI, you'll miss it out. So I have done ACI with posterior labrum tear repair in 2 stages for some of these. So that's something that you cannot cover. And the retroverted glenoid, I don't know. I have asked so many colleagues abroad. Some of them say do an osteotomy, some of them don't, because it doesn't change anything, the osteotomy. The results aren't good.
So one question would be, MRI wouldn't show much of changes. Would you, and patient do complain of posterior pain, would you consider doing an MRI arthrogram in these patients with a vague posterior pain, MRI is not showing much? Would you hesitate or?
Not really. With a 3 Tesla MRI, I don't think we have any problem. It just solves everything. Our last contrast guide MRI was done in 2007. But that's when the 3 Tesla came into Pune. So I don't want the radiologists invading the joint in a non-sterile environment. They don't have the same sterile techniques that we have. We worship the joint. So I don't think there's much to achieve with the GAD.
We just got the 3 Tesla now.
Oh, not bad. See, you'll see that big difference now. Actually, I did a nice webinar with Alex Ladaman for BMed and on posterior, the wide. So I've concluded all of this on that. So those who are interested might want to go to BMed and watch that.
Thank you,
Sir, how do you address the reverse hill sac if found?
So with instability, it's never a problem because it's usually subtle, small. You don't want to do anything as long as you're lived. What Sumanth said was the posterior labrum is not weaker. It is thinner. It doesn't have the same profile as anterior labrum. So pick up a capsule and make it nice and thick. Number one, and the posterior capsule is very lax. When you're dealing with a neglected or a persistent posterior shoulder, that's when the reverse hill sac is big. Then you need to fix that.
Sir, is there any particular number like an anterior Bankart, the minimum 3 anchors have to be put for instability?
It depends on the length of the tear. So if your tear is the full length, then you put in 3 anchors at least.
In my practice, usually I see 2 types of posterior labral tears. Some patients, they come very early, then always try to repair it, But whenever, when we found there is significant posterior glenoid erosion with a loss of cartilage and the posterior decentering of the head, then these cases are really difficult to manage, like what Bablukar sir said. But most of the early cases, I said almost 70-80% of the cases we can always repair nicely, And most of these patients are wrestlers who do a lot of push-ups and these kind of groups.